A very good evening to all of you. Today I'll be presenting on Tango with Congo at the Caruncle. Yeah. So the disease associated with Congo, or rather the Congo red in particular, is amyloidosis, which is a heterogeneous group of diseases which involves deposition of abnormally folded amyloid proteins in the extracellular spaces. These are usually localized or systemic, and ocular involvement is very infrequent, the most common site being the eyelid. So here is a case where there's a rare presentation of ocular amyloidosis. This was a 38-year-old gentleman who presented with a painless swelling at the innermost corner of his eye for about 4 years of duration. He gives no history of trauma or ocular surgeries. He has no other systemic diseases, or his medical history was unremarkable. So on detailed ocular examination, there was a pedunculated mass arising from the caruncle, which had a corrugated swelling surface, and it was mildly pigmented, not bleeding exactly on touch, and the underlying tissue appeared to be mildly involved. On looking at the rest of the anterior segment, it was within normal limits, also was the posterior segment, and lymphadenopathy examination was also negative for any nodes. So we decided to do imaging for this patient to know if there was a deeper extent or involvement of the lesion. And there was a well-defined mass at the in the caruncular region, which was hyperintense on T1 weighted imaging and hypointense on T2 weighted imaging. And it also took up contrast enhancement. So at this point, though I suggested an incisional biopsy to the patient, he was very impatient to get the whole thing removed. So considering it to be a probable malignant lesion as well as a DD, we went ahead with a complete surgical excision with 3 mm margin clearance on the conjunctival side. And cryotherapy was done to the edges and the base, and the defect was reconstructed with amniotic membrane graft. A histopathology examination showed multiple eosinophilic amyloid fibrils deposition, which took up a salmon pink color on the Congo red staining, and a typical apple green birefringence was seen under polarized light microscopy. So this was a clinching diagnosis of amyloidosis. A systemic evaluation in the form of complete blood count and coagulation profile was done. Peripheral smear and bone marrow biopsy was done, which was normal. Urine protein was elevated along with B2 macroglobulin, but on electrophoresis, M band was absent, ruling out multiple myeloma. A rectal biopsy and abdominal fat aspirate was done, which was normal. Echo was normal, and rheumatological workup was also normal. Having ruled out a systemic involvement, now our diagnosis was a primary localized amyloidosis of the caruncle. The patient is currently under follow-up with no recurrence. As we saw earlier, the ocular amyloidosis is rare. It presents late because of its slow progression, and ptosis is usually the most common presentation. And so far, only a single case of lid and caruncular amyloidosis has been reported in literature. Gold standard in periocular amyloidosis is a tissue biopsy, whereby we saw the typical features that are seen on histopathology. Systemic evaluation is to rule out any other systemic involvement by amyloidosis, since the management can vary in those cases. And surgical debulking with cryotherapy is suggested for periocular involvement of amyloidosis. This may be given along with radiotherapy, especially for deep-seated lesions, orbital lesions. And this is the primary treatment in case of localized amyloidosis. So that's all. Thank you.